Hi everyone, welcome to our video series on osteoarthritis presented by Craven SPORT Services. My name is Jared Stevens and I'm going to be taking you through a three-part video series on different aspects of osteoarthritis. In today's video, we're going to go over what is osteoarthritis, and in subsequent videos, we'll go over different treatment options and as well why exercise is the preferred treatment option here at Craven SPORT Services. In today's video, we're going to look at what is osteoarthritis. We're going to look at different risk factors for developing OA, both the modifiable and non-modifiable factors, and how we go about diagnosing osteoarthritis. So what is osteoarthritis? Osteoarthritis is a degenerative joint process that can arise from a variety of reasons involving a variety of symptoms. So it's a pretty broad term. It falls under the umbrella category of arthritis. So there is a number of different kinds of arthritis. There is rheumatoid arthritis, psoriatic arthritis, gout is also another kind of arthritis. To break down the term osteoarthritis, osteo refers to bone, arth means joint, and itis is anything that involves inflammation. So you have an inflammation in between the joints in your bones. Osteoarthritis, or OA as it's more commonly known as, is typically characterized by joint stiffness, joint pain, degenerative changes such as to your cartilage, ligaments, capsule, or bone. Degenerative just means a wearing down over the course of time. Functional limitations, meaning that I can't go up the stairs as well as I used to, I can't do this, I can't do that as effectively. Decreases in range of motion, so you can't move that joint as far as you could before. New snapping, cracking, or popping, different sounds coming from the joint, and then just an overall decreased confidence that I don't trust my leg to do this anymore. I can't do that without worrying about it anymore. Osteoarthritis is classically thought of as a wear and tear, and that's in quotation marks, disease. So an analogy that's often used is the tires on your car. So if you get a new set of tires on your car, you can expect to get maybe 70 or 80,000 kilometers on them, and then those tires will wear out, and then you will need a new set of tires. So if we apply that to osteoarthritis, that would suggest that the older we get and the more active we are, you're automatically more at risk for getting arthritis. But what we're finding now is that the prevalence of knee OA specifically, but this applies to other kinds of arthritis as well, is increased drastically in the 20th century independent of these factors, meaning that it's happening a lot more without taking those other factors into consideration. So osteoarthritis is not a reversible or curable issue. I put yet in there because there's different research going on in some different areas, but as at this time, it is not reversible, it's not curable, but it's very, very manageable. We can't make it so that you do not have osteoarthritis anymore, but we can make it so that the symptoms and things that you feel while having arthritis is much, much less. So if we look at risk factors for developing osteoarthritis, we can kind of break it into two categories. There's either non-modifiable factors or there's modifiable factors. Non-modifiable are things that we cannot control, and modifiable are things that we obviously can control. So if you are over the age of 40 years old, if you are a female and not a male, and if one or both of your parents had arthritis, then that's simply bad luck and you were dealt a tough hand at birth. So if you're a 60-year-old female whose both parents had arthritis, your risk of getting arthritis is higher than a 35-year-old male that neither of his parents had arthritis. So those are things that we can't do anything about. That's the way that we were born. So we don't really worry about those. The things that we do focus more so are on the modifiable issues. So modifiable issues can kind of be broken down into four main categories, although there is more, but these are kind of the main ones. So the first thing that we can control in terms of developing OA is joint injury. So as soon as we sustain any kind of injury to a joint, that increases the prevalence of earlier onset. So a common example for this is if you've ever heard of an ACL injury in a knee, and the ACL is a strong ligament that helps to stabilize your knee. If you have an ACL injury when you're younger, the instant that ACL happens, your risk of getting arthritis increases immediately in the next 10 to 15 years following that injury. This is listed under modifiable factors because oftentimes joint injuries are prevented through proper training and other things like that. Being overweight or obese is another issue that can contribute to the development of OA. The reason that your body weight has such a major impact on your joints is that every time that you're walking or going up or down stairs, your joints in your legs have to absorb 3 to 5 times the amount of your body weight every time that you take a step. So if you weigh 100 kilograms, every time that you take a step going down the stairs, your ankles, your knees, and your hips are absolutely absorbing about 500 kilograms every time you take a step. So decreasing your body weight by as little as 3 to 5 kilograms can have a massive impact on the effect that your body weight has on your joints. Kind of along that note, muscle weakness, your muscles act as a shock absorber for your joints. So if you don't have the muscle strength surrounding your joint that you need, then more force is going to be transmitted through the joint, which can contribute to that degenerative process that I brought up before. And the last thing noted on this slide here is inappropriate demand. So this can encompass a number of different things, but to simplify it, you can think of it as either joint overload or joint underload. So joint overload is not something that happens over the course of a day or a weekend or even a week. This happens over the course of many, many weeks, months, and years at a time. So if you had a big weekend of gardening and now your knee arthritis started to bother you more, you didn't develop the knee arthritis over the weekend, but that activity did probably exacerbate it. Now, on the other side of the equation, joint underload is a very, very big factor in this. So if you don't do enough activity to maintain the health of your joints, the health of your joints will deteriorate, and that contributes to the development of arthritis as well. Cartilage is a smooth surface that is on the ends of all the bones in all of your body. So the primary purposes of cartilage is to help to absorb shock and distribute pressure throughout the joint, as well as a nice smooth surface so that your joints can slide really easily. When we're born, all that cartilage in our body is nice and silky smooth like glass. Now, this cartilage does not have any direct nerve or blood supply, so this is kind of an important factor with this. So since cartilage does not have any nerve or blood supply, that means that it can't rely on blood to get the nutrients and oxygen and things like that that it needs to stay healthy, and it can't take the waste products away as well either. So all of the other tissues in your body, your muscles, your bones, your hair, your fingernails, all has blood flow to it. So that's how things can stay healthy, whereas cartilage does not have that. So because of that, cartilage needs to be nourished via weight bearing and movement. We'll talk about that in a little bit more detail going forwards, but we need to move in order to keep that cartilage healthy in our knees. Cartilage is constantly undergoing this degeneration and regeneration process, meaning that things are constantly being broken back down and built back up. Broken back down and built back up. That's how every tissue in our body stays healthy. So when you go to the gym and do a workout, you actually degenerate the muscles that you're training, and then over the next 24 to 48 hours they regenerate and get back stronger. So this happens to every tissue in our body. Problems arise with cartilage when the rate of degeneration starts to exceed regeneration, meaning that we're losing more than we're gaining. So as time goes on, rather than this smooth wave going up and down, the cartilage is starting to get a little bit worn down, and we can't regenerate it as quickly as we did before. This is a picture of your knee joint. The bone on top is your thigh bone. The bone on the bottom is your shin bone, so that we're looking at your knee joint. The blue, shiny looking surface is the cartilage in between the two bones. So on the left, that cartilage looks really nice and silky smooth, whereas as we progress towards the right, there gets to be a little bit less space between the joints, the cartilage is not as smooth as it was before, and that's how OA progresses. Now, to put some more medical terms to it, we go from normal cartilage on the left, and as OA tends to progress, the cartilage gets these fibrillations or cracks in it, and then it leads to hardening and some cysts develop until eventually there's no cartilage, when this would be the most severe form of arthritis. So if you've ever been told that you have bone on bone, that is indicating that all of the cartilage is gone from the joint, although that's not exactly how it works. That's what that is suggesting. This is an example in the hip now. So the bone on the left of the picture is your thigh bone, and then the bone in the middle is the pelvis. So this is your leg bone fitting into your pelvis. On the left, we have this nice healthy cartilage between our thigh bone and our pelvis, whereas on the right, you can see that the cartilage has some more holes and cracks. there's less space between your thigh bone and your pelvis, and this would be a more progressed form of osteoarthritis in the hip. So now that we know that what arthritis is and why it happens and how it progresses, the question arises, well, how do we diagnose it? Typically, osteoarthritis is diagnosed through a combination of signs and symptoms and some type of imaging. So signs are things that I can see in you, like redness or swelling, things like that. Symptoms are things that I can't see but you feel. So you can feel shooting pain or aching or things along those lines. Imaging can encompass a number of different things, but the most common is through X-ray. Sometimes a CT scan or MRI can be used, but X-ray is the most common. Now, this is a very common misunderstanding about arthritis, is that the imaging is the most important factor in diagnosing it. But there are actually a lot of challenges with diagnosing OA with imaging. So the two main ones are that there's a major time lag between severity and imaging, and there's a really poor correlation between imaging and symptoms. So what I mean by that is a person can have a very poor looking X-ray, meaning that they have, quote, severe degeneration between their shin bone and their thigh bone, or they can have an X-ray that shows very little degeneration. The person that has very severe findings can often have very little pain or symptoms, whereas the person that does not have severe findings on imaging can feel very little pain at all. So sometimes there's a very poor correlation between these two things. So if you're looking at trying to diagnose OA through just the use of imaging, then it's not a very effective way to look at the full picture. So I've often had people come into my room and show me a picture of their X-ray saying that I have severe degeneration. I've been told I can't do this, I can't do that. And when I ask them how they feel, they'll say it's a little bit stiff here and there. And then the same thing can happen on the other end of the spectrum, where a person has a severe pain, but the X-ray shows that they don't have degeneration, where if a person has very high symptoms or a lot of pain, to be honest, I don't really care what the X-ray shows, because it's more important to treat the person in front of you than what the X-ray shows. This is kind of a pet peeve of mine and many other physios, with not only with arthritis, but with other imaging techniques like MRIs for the back, for example, but that's not really an issue for this video. Because of these challenges, osteoarthritis can be positively diagnosed on signs and symptoms alone, meaning that we do not need an X-ray in order to diagnose OA. With current evidence right now, if you are over the age of 40 years old, if you have short-term morning stiffness, so things are stiff when you get up and moving and then they loosen up as you get moving more, you have pain in that joint with use, you're limited functionally, meaning I can't do this thing that I used to be able to do, and you have some more cracking or popping, some restricted movement, or the bones are enlarged, then we can accurately diagnose OA on those basis alone. We do not need an X-ray. Sometimes it can be a helpful piece to the puzzle, but it is not a necessity to accurately diagnose OA. So that is a summary of what osteoarthritis is, the risk factors for developing it, and how we diagnose it. So in part 2 of this series, we're going to go over the different treatments